everyone present here, and I would like to welcome Dr. Vishal Chhabra, who has been kind enough to accept our invitation and be part of the medical advocacy program that FACEMI has initiated. So welcome, Dr. Chhabra. I would like to give a brief introduction of Dr. Chhabra here first. He is a graduate and postgraduate from Kasturba Medical College, Manipal. He has 23 years of experience in clinical practice after completing his post-graduation while working in esteemed institutions like IBAS, GTB Hospital, Wimhans, a metro group of hospitals. He is currently the HOD and Senior Consultant at Fortis Hospital, Shalimar Bagh, and also visiting two of their other hospitals in Okhla and Vasant Kunj. And as of yesterday, he is also Director of Academics at IADU. So congratulations, sir. He is founder and director, Chhabra Psychiatry Center, Rohini, Delhi. He is Life Fellow of Indian Psychiatric Society, Indian Association of Biological Psychiatry, Indian Association of Social Psychiatry, and Indian Association of Private Psychiatry. He is the recipient of Ravi Pandey Memorial Award 2006, WPA Fellowship in Child Psychiatry 2008, and Asian Federation Fellowship 2012. He has 15 published articles in indexed journals and 2 chapters in the psychiatry textbook, besides also on the Delhi Psychiatry Journal editorial board. He was President, Vice President, General Secretary, and Treasurer of the Delhi Psychiatric Society at different times, which is the largest association of psychiatrists and psychologists in Delhi NCR. During his presidency, he had initiated various academic activities with more focus on budding psychiatrists and increasing membership of young psychiatrists. He was co-chairman of the IPS, the Indian He was also the chairperson LGBT Task Force of the Indian Psychiatric Society 22-23 and the Headquarters Subcommittee 21-22. He is the founder president of the Rotract Club of Mahe, where during his MBBS days, and started as a host of activities like health camps, school visits, meditation classes, etc. for members and community at large. His areas of academic interest include phenomenology, mood disorders, anxiety disorders, OCD, addiction disorders, psychopharmacology, and role of AI in psychiatry. In his free time, he is interested in delivering public lectures on mental health, enjoying personal development books and courses, history, geopolitical, photography, traveling, and exploring spiritual dimensions of life. So, very, very experienced and esteemed guest we have here today, and I hope we have we make the most of his presence here today. Thank you for joining us today, Mr. Dr. Chhabra, and I hand it over to you now.
Yes, hi. Good evening, everyone. Sorry, I had to rush because the patient, there's still a patient waiting in front of me. Somebody has just come in last. So when they told me about to talk about this topic, I thought we will talk about doctor-patient relationship and also about family relationship with the patient, because that is also very important and vital in recovery in our patients. So this is called nocebo effect. Negative effect, thinking something negative, negative happens. Thinking something positive, positive happens. This is important. ये भी important है. If you give sugar pills for a longer time, they will stop working. The placebo effect will go away sometime. Nocebo effect will go away sometime. But to start something, this helps. Nahi to, I keep telling my patients, I keep telling myself, see, I've learned over time, I cannot treat all patients. All patients will not get better with me. Earlier, when I was younger, I had this cockiness, proud that I'm studied from a good college, I learned so much. I can treat all patients. I have realized over time, I cannot treat all patients. See, like how, like all, people go and pray in temples, mosques, churches. Your prayers don't get answered in the single temple. ये तो वही temple होता ना, city में और temples की जरूरत ही नहीं. You have big temples, big temples, and smaller temple nearby is also there existing. Why is the temple there? So because some people are getting help there also. Correct, है ना? Otherwise, why would Kashi Vishwanath temple have another 10 temples next to it? No need, na? This is the only temple. So not everyone gets treated by a single doctor. So everyone is fit for everyone else. सबकी अपना अपना, because there are other dynamics working here also. Personality also works here. My personality may suit certain patients, may not suit certain patients. My fit of medicines may not suit certain people. So a lot of factors are there which affects. Why am I saying all this? Because as families, you should realize just because you went to three doctors and your child is not getting better doesn't mean the child will not get better. And also, maybe you're going with a negative effect, with the nocebo effect in your mind. That is also a possibility. So all this is important for us to understand as families. Also, you have to understand that illnesses are chronic mental illnesses are long term, they're lifelong. In lifelong illnesses, the goal is to improve the functionality of the individual. What are we treating in psychiatry? We are treating in psychiatry functionality of the individual. I might think sitting here, I am the king of the world, and all world prays to me, bows to me, and I have the power to do anything I want. But if I'm able to sit here and talk to you normally without showing those kind of features to you, if I'm seeing my patients properly, if I'm behaving normally in the house, if I'm behaving normally in the society, this kind of delusion, this is called a delusion, no? This kind of thinking is not treatable. Nobody will come. No, first of all, nobody will get to know, so nobody will bring me for treatment. I am not affected, so I will not come myself to the treatment. So what I'm trying to tell you here with this crude example, we are looking here at improving functionality of an individual. Right? Very important to understand. Functionality of an individual. If functionality is disturbed, then we need to help those individuals. And if you look whether the patient has schizophrenia, whether the patient has bipolar, the patient has depression, the patient has OCD, only when their functioning is disturbed. Otherwise, patients don't. Tabhi to patients come to doctors so late, 5 years, 10 years down the line. When everybody is affected, but family is not able to take it anymore. Patient not able to take it on. Then only they come to us. No? Initially, nobody comes. So suppose somebody is washing hands, OCD. So somebody is washing hands repeatedly. Correct? So somebody is handing 3-4 times and then it's not bothering anyone. Nobody is bothered. Nobody is saying anything. But same person now washes 10 times. 10 times the washing hand is standing on the wash basin, just washing hand. Food is getting cold, they're just washing hands. Also, they're telling others to wash hands. Wash hands, then only I'll eat food. Wash hands, then you cook food. So now, functionality of that individual, functionality of other people are getting affected. Then only they come to us. Does it make sense? Correct, no? So this is important to understand. What are we looking here? What are we doing with all our treatment? What psychotherapies, with medication, with ECT? We're improving the functionality of an individual. So, my message to all of you, you educate other people. Don't be shy of the treatment. The earlier you start a treatment, the faster the chances of recovery. The earlier you start a treatment, lesser chances of dysfunction, or what do you call that as? Residual symptoms. Residual symptoms means patient never gets fully all right. थोड़ा बहुत problem उसको रह रहा है. Some symptom is there. Some depression is there. Some fear is there. Some anxiety is there, which is persisting. We need to make sure if we start treatment on time, early, identify early, start early, and continue treatment, then recovery chances are higher. We also need to remember that you have the right to ask your doctor if no change is happening in the patient. You have that right. You should ask that doctor. You should ask your doctor questions. What more we can do to help the patient? Why this is happening? What is happening? I see so many times patient comes to me after 10, 15 years of treatment. They change the doctor, they come into me. They don't know what patient has. The family doesn't know what patient has. No? You should understand what patient has. Not that I'm not saying you to read everything on Google, which is opposite side of people reading on Google and diagnosing themselves. That's a separate thing. But you as family should know. If you're taking treatment for diabetes, you should know now you have diabetes. If you have hypertension, you should know you have diabetes, hypertension. Same if if your child is taking treatment for schizophrenia, you should know taking for schizophrenia. So many times people don't ask. So many times doctors don't tell. So they don't know what is happening. So this is important to enable you, to make you, knowledge empowers you. Knowledge empowers you. Uh, so I see a lot of people, either they don't know anything or they read too much on the internet. Too much knowledge is also dangerous. So that then they read up and they're all scared. That is also not good. Now I want to talk about doctor-patient relationships. What changes I have seen, what changes have happened over time. So earlier, my father also doctor, there was a different way doctors were, taking care of patients. That was more like a parent-child relationship. आजकल पेरेंट चाइल्ड रिलेशनशिप भी चेंज हो गया ना लाइक आर टाइम इफ पेरेंट ने बोल दिया इसे शादी करनी है तो करनी है पॉइंट खत्म अगर ये खाना खाना है तो खत्म ये करियर चूज करना है तो खत्म यू don't have any decisive powers. You can crib and cry, but what has been told is will be done. That model has changed significantly. I Then there is another model in US or in Western countries. I'm giving you information. You decide whatever you want to do. You do it. I am just giving you just giving the information. Now, we don't even know how to buy a nice, let's say, which TV to buy. They give you all the information that if you go to any electronic shop, they give you all the information about TV. Can you buy a TV? You don't know about the TVs. For TV also, we don't know. How would a doctor, a patient knows about treatment? So just giving information, that's like a customer thing. I'm giving you you're my client, I'm giving you service, you pay me money, I'm giving you information, you decide whatever you want to do. That's also not a very good thing, especially in this field, because if I have now experience of 25 years, reading on the net, just giving information is not enough. So many things are left unsaid, which is not possible to tell. So this model is also there, informative model. Then there is another model where interpretive model. I mean, I help you decide, but you decide. But I'll help you more. So this is a little more, there's a more active participation. Earlier was informative, I've given information, you decide. Now active participation. I'm helping you decide, what you like, what you don't like. Based on that, I help you decide. But now, what we are doing, what I'm doing, and what is now being taught is a deliberative model, which is I will take the final call, but I'm helping you understand much, much more. You won't believe if all my patients I treat, I tell them, see, you're not doing better. I think you should stop this medicine. Are you okay with stopping this medicine? This is very commonly I do with my patient. I don't reduce or increase any medicine without talking to my patients. I tell them, Acha, now you're having this issue. Should we give this? Let's try this out. So many times patient comes, hey, doctor, I'm very suspicious of medicine, or I don't want side effects. So, okay, if that is how it is, let me start you with the baby dose. And I'm okay if you stop it also. So with this medicine, first week I'm going to give you this medicine. You'll have no effect, but also no side effects. So your job is also done, but at least your body will get used to this medicine. Then next time we'll start. If you're more confident, then we'll go it. So what I'm doing, building trust with the patient. So this interactive model, this participatory model is much better, because I'm helping my patients. Same as with with the family members. For bipolar, especially for bipolar, because bipolar may you have. Uh, I'm assuming you guys know a lot of information. This is why I'm saying it. You have high phases, manic phases. You have low phases, depressive phase, right? So sometimes high phase come very quickly within 3 4 days, and if you don't act then and there, sometimes the illness may prolong for the episode may prolong for 1 or 2 months and can be disruptive. Patient spends a lot of money, gets very aggressive, hyper, whatnot. To avoid that, I tell partners, wives or husbands, or sons or daughters or whatever, or parents, what are the early signs of relapse and what action you need to take. Don't need to even come to me. Just do it yourself. This is an SOS when you start it away, because you may take 2 days to come to me. You may take time in getting an appointment. You may not have time, but don't waste those 2 days. Those 2 days can be very critical, especially in bipolar patients. So what am I doing here? I am helping, not only I'm helping patient understand treatment, which I do, but I'm also helping family become co-therapists with me. Doctors actually, or nurses. Glorify, I mean nurse, because nurse can give medicine, right? So I'm teaching them, I'm helping them ki, do this, give this medicine, so that we can immediately cease or reduce the episode, as fast as possible. So this is the model I'm practicing right now. I'm not at all a parent, you know, but sometimes when patient is not able to understand, sometimes when patient is not able to, then you have to switch between these models. My major model is deliberative. Take patient, help him or her understand the illness, and help them take decisions along. So they feel they're taking decisions. I am taking decisions for them, but they feel in charge or part of the treatment process, not just passive recipient. You know, that reduces the stigma also. कि because they mentally उनको कुछ नहीं पता है. I'm going to be no. They are participatory in this. So I do this even with schizophrenic patients. They are participatory. Here's a tip for all of you. In schizophrenia, there is something called there's a denial of illness. They don't remember, they don't recognize they have an illness, unfortunately. So I think I had a book here. I'm trying to see. So long ago, I attended a workshop with this man who's also a psychologist. His brother was a schizophrenic. He learned over time that there's no point shouting at him, screaming at him, pressurizing him to take medicine, threatening him कि admit करा दूंगा. The only way that man took medicine is because he said he felt this therapist, this psychologist, was like a brother, friend to him. He was a brother, but friend to him. He was a well-wisher. So I've learned that the lesson very, very important. In schizophrenia, patients take medicine not because they're ill. They take because they family members who love them tell them to take medicines. So having a good relationship with the schizophrenic patients is very, very important. Have a good bonding with them is very important. It's sometimes difficult, but this is important for us to, so that they are not taking because they are ill. They're taking, अच्छा आप बोल रहे हो ना, that's why I'm taking it for you. Unconsciously, they're doing this. Okay, because schizophrenia, one of the hallmarks of schizophrenia is lack of insight. Some patients do get insight, but most of the patients do not have insight. So this kind of bonding is important. Instead of threat, bonding, love and care is important. Okay. Any other thoughts I'm thinking? I think I made some notes to see if I have anything else. Another thing I do with my patients, I laugh with them. I joke with them. I have fun with them. As a doctor, it keeps me also light because, if you are always serious all the time, it can start paying, it start weighing on your mind. You become little irritable, you can become little cold, you lose empathy because you get burned out. So for that, it's important. I think from my side, this is my own thing. I play a joke with my patients. I ask little simple things like, you're preparing for exams. What happened to the exams? You're supposed to go for how was the vacation? You went for this function. Did you enjoy it? Did you wear a good dress? I also sometimes joke with them. I make jokes on them. Make jokes on me to help them laugh. So we have all these kind of funs to make the conversation going light. So they're not scared. Doctors don't realize that patients are scared of them and they lie to you. 70 to 80% of patients don't take their medicines regularly. 70 to 80%. It's almost everyone. But when you are light with them, when you joke with them, they do tell you. And when you don't scream at them, when you don't shout at them, it's okay if you didn't take it's okay. But be careful, do take it regularly. They feel friendly atmosphere. So they become more bonded with the doctor. I think this is very important for us to remember. We all miss medicines. This 80, 70, 80% thing is not just for mental health. Across all specialties, patients miss their medicines regularly. Not because mentally ill, because it's a human nature to forget. No, you forget, you forget, you forget. But doctor को जाके नहीं बताते. So how I get to know is patient was doing fine. Patient comes to me after 2 months, supposed to come after 1 month, and sad again, or anxious again, or upset again. Or now today, one girl was crying a lot. All I ask is, are you taking medicines regularly? Normally, patient will say yes. I said, Pakka, when was the last time you took medicine? 15 days ago. That's not regular, no? 15 days are done. You're not taking medicine 15 days. So, if they don't tell, let me tell you practically. If you lie to your doctor, what will doctor think? I'm giving him 10 mg of this, 15 mg of this, 100 mg of this. Not better, increase the dose. You increase the dose, what happens? Side effects happens. Sedation happens. What will happen? What will patient think? I will not take it. I will skip the medicine more. You see the cycle, vicious cycle? So it's very important that we have an open communication with the patient, which I try as much as possible. And let them be honest. Let them make a mistake. It's okay if they didn't take medicine a few days. But we keep warning them. So this way, you're like a friend, like an elder brother, or or somebody they look up to. I think this is very important. This is called therapeutic alliance in psychiatry. We have Dr. Patient in his alliance. This is an alliance. We are together in this. Marriage is also an alliance. This is an alliance. We are together in this. So we both agree what we want. I tell patients, Doctor Saab, black magic is done on me. Doctor Saab, my neighbors are trying to harm me. Doctor Saab, they're going to do this. I said, I'm there for you. Take this medicine. Nobody will say anything to you. If there's anything, you tell me. Because actually, nobody said anything to a schizophrenic patient. No one says. They keep fearing all the time. But really, nobody says, no? I said, next time anybody touches you, come and tell me. I'll take care of that person. So they feel trust in you. Right? And this helps them feel strengthened. Instead of saying, no, this is all lie. This is all your imagination. Patient will not understand this. The schizophrenic patient won't understand this. So I think from where my approach changes is, I said, okay, I will take care of you. You just take the medicine. I'll take care of you. You have to take care of your medicines. Done. Deal done. That's okay. So this way, And you know that when they take medicines, the fear goes down, the suspiciousness goes down, the anxiety goes down, and they are better. This is important. So this is therapeutic alliance where we are agreeing on goals. We're agreeing on certain things. If you sleep on time, you get up on time. All my patients, uh, because I see mostly, and it is true in any practice, you get mostly anxiety, depression patients. I said, why you want to get better? Sometimes patients say, I'm ill for 10 years, 12 years. I have panic attack, I have anxiety, depression. I said, why you want to get better? What is the role? What is the goal in your life? People don't have goals. So I tell them to have goals. As long as you have goals, your mind is focused on that task. Like I had a goal to meet all of you at 8 o'clock. You won't believe the speed with which I saw patients. I don't usually see patients so fast because there's a goal attached to it. I'm not happy because I don't like seeing patients too fast, but I had to do it because there's a goal. So it's important to have goals. Goals give your mind directions. If you're goalless, the mind will wander. Mind's basic ability is to wander. Basic, sorry, not ability, basic function is to wander. It just wanders. Mind's basic thing, again, it wanders towards negativity. Basic, it's evolutionary thing. You can't stop it. When you say think positive, it is so tiring to think positive because negative keeps coming in. I missed it whether Sindhuja talked about me exploring spiritual dimensions of life. Did you mention that? Did I send you that?
Yes, sir. Just this one, one line, the last
Yeah,
one.
this
Yeah.
is the
Yeah.
reason I did do that is that has helped me smile, keep myself afloat, smiling and happy, even after 25 years of this. Because you realize that, but there are other things, you realize how mind is, how tricky mind is, and this is important to teach patients of anxiety and OCD because they keep grappling and dabbling with their thoughts. And because they're not psychotic, they have the insight. Why am I drowning in my thoughts? But they can't control it. Right? So dabbling into all this, why mind works, what is the quality of our mind, what are thoughts, how do they work, helps me coach them better, helps me support them better. Right? And for myself also. Because I also get upset. I also get anxious. I also get sad. I get also angry. They're human, these are our human emotions. We accept that. It's important to acceptance आते ही आधी चीजें तो ठीक हो जाती. If you accept your anxiety, anxiety goes down. It does because you're accepting it, and you can make a fun at yourself. कि देखो now you're panicking again. So it goes down, right? And you said, okay, so you're getting angry again. Oh, ego is going up again. Huh? Think too much about yourself. So that happens. Most of the actually, so what has happened over time is I have learned from my patients how to be a better human being because I see them making mistakes which I could have also done. But because, see, this is a beautiful way of looking at psychiatry. This is so when a couple is coming and fighting and coming to me and fighting over it, I also have petty issues with my wife also, and I see where they're fighting. I can do the same thing. So you learn with that. When you see people getting anxious over results, over money, over so much other stuff, relationships, you realize, yet this also can happen to me or happening to me. Then you learn from them how to be better. So when you're telling them, I mean, for me to think I'm above everyone, I'm beyond everything just because this is wrong, right? It's not true. You have this data. UK में the highest suicides are seen in psychiatrists. Second are dentists. This is UK figures. India में नहीं है ऐसा. I don't know why is that, but this is important for us to understand. So I think what is important is that we need to learn. So when you do this, you're more open. So what I'm trying to say indirectly, Be more open to experiences. Have an open mind. Learn from others. You can learn from your patients. You can learn from the families how they're dealing with the patients. Sometimes, see, I don't have patience, but sometimes families have so much of patience with the patients. कैसे manage कर लेते हैं? How do they do it? It's so wonderful. I wish I had that much of patience. So you learn so much. So that's another way of looking at things. So though I am in a more powerful position than my patients, I'm using that power in a more subtle way in helping them understand the illness, understand the medications, understand the course of the disease, and also strengthening them and their families to deal with this illness. But sometimes it can be tough. There's something called as transference. Patients may be more upset with you because they're looking in you some father figure or some other figure which they hate or which they love. So transference can happen either somebody may be very upset with you, or opposite can also happen. From doctor side also there can be counter transference. Certain people you don't like, you don't want to see, it irritates you. Because that person reminds you of somebody else you had a bad relationship with, or some people you like a lot more because that reminds you of somebody else, which was so much nicer to you. So these are forces which also happens in an interaction between a doctor and a patient. Coming to the confidentiality. The confidential is an important part in India. In India, it's not respected much, at least initially. So when everybody comes in, 3-4 people have come in, they are only talking, patient is sitting quiet, patient is not well, doctor's noting down history, given the medicine, all of them go out. Again, next time they all come in, given medication, go sent and go in. Sometimes you realize you haven't spoken to patient ever alone. And after maybe 1 year, you talk to patient alone, patient tells you something, oh, if I had asked on the first day, things would have been different. I didn't know this was the stress. So I make it a point to talk to the patient alone, always, and to the family alone, always, and then together. This helps in understanding the family dynamics also. If you're an overprotective parent, overprotective spouse, you get to see immediately. If there's somebody nagging wife, nagging parents, you get to see that also. So an interaction alone, an interaction separately is also very, very important part of the treatment itself. This itself is therapeutic. I think I've spoken for a long time. I don't know if you have any questions, anything.
There are quite a few questions, sir, actually. There were some of them were shared earlier by some people who are in the meeting and by some who could not join the meeting today, but they also wanted to send their questions. So I would now hand it over to Saraswati to moderate the question answer session. Saraswati, over to you.
Yeah, thank you, Santocha.
Before that, any queries on what I've spoken? Anything you want to ask? Anything?
Yes, sir. We would like to finish those questions or something related so that if somebody else has similar questions, those could be answered. Because from what you have spoken and the questions, because they were collated by me, some of them are very, very related to what you just spoke. Even if the person is not attended the meeting, there is a lot of, about those questions do relate to what you have spoken about. So yeah, so we will continue with that.
Okay. So the first, we have about 7-8 questions which have already been shared with us. Okay. So the first question is, on several occasions, I have faced dilemma of being torn between patient and psychiatrist. Both of them come up with solutions which are not always practical. So what do I do?
Find a middle path somewhere. That's what we have to do. Like what kind of if you can be more specific and answer that. I mean, if you have that person can answer.
No, I'm not sure the person is there, but this is
what. Let me give you an answer. Let's say As a doctor, I like to write 5 medicines per patient. That's it. Doctor says, a patient says, मुझे एक भी medicine नहीं खानी. Now, the demand from both sides. Now, I'm screaming at the mother, why are you not giving your son all the 5 medicines I've given? He'll never get better. So she's guilty. Now, son is saying, I will not eat any medicine. Your medicines, the doctor's medicines are so sedating, so much side effects. I don't want to take. Now, what do you do? So, the best way is, because this keeps happening with our patients, I'd say, okay, let's take 2 medicines. Huh? Let's take 2 medicines, not 5. Let's have 2 medicines. So that is possible. So negotiation with the patient in front of the family to say, okay, तुम 2 medicine तो ले लो, and maybe the child may want to go out or eat once a week outside or go out somewhere or something. Some compromise can happen. So this is what we need to do practically.
Absolutely. Negotiations. Give and take.
Yes.
When do we seek second opinion? I think this is a dilemma for a lot of us.
So I think it's important. Second opinion should happen when you feel there's no change happening in the patient. And with the doctor also, the warmth is gone.
Okay.
And that happens. I mean, I myself tell some patients, now I'm tired of you because you have left my medicines 10 times, I've come back 10. I don't want to see you. Please go somewhere else because I am not in a state of mind to see you again. Because I've lost that empathy for you. This happened only yesterday only. But then again, begged and pleaded and sat down. I said, you go somewhere else because I've already lost, because you've done this to me multiple times. So second opinion happens when your patient is not getting better, when your alliance with doctor is not working out, you're not enjoying the doctor. Just your doctor is not reachable, some emergency, so let's say you're too anxious and doctor is not reachable at all. Now, what do you do? So that kind of thing, or patient is deteriorating and despite changing medicine is not working out. Because again, I'm saying, sometimes you just don't get the grip of the patient. You don't understand what's happening. Another doctor understands it within a minute. Then this is happening. So when patient is sliding down, patient-doctor is not sharing a good relationship, or you see nothing happening despite being regular on treatment, then probably get a second opinion.
Okay. So in your conversation, you said that, you spend a lot of time with the patient and separately with the family and then together. So I think, why do other psychiatrists look at the symptoms first and the person later or never?
So I think it's to do with the training, how training has happened. Now that workload have also increased with me. Like today, I could not do what I was trying to tell you. But my basic nature is I want to get into the depth of the patient. That's my basic nature. But not everybody doctor may have the same thing. And you may get the similar results also. I found it very surprising. My colleague of mine who spends just 2 minutes per patient, he also has a good OPD. I'm spending 20 minutes. I had lesser OPD than him at one time. But it is, and patients are still going to him. Because some patients don't want to spend too much time. They just want to take the medicine and go. Some patients, again, personality to personality, want to get into the details of things. For them, maybe I'm a good fit. Maybe if a patient who wants to come and quickly show, maybe I'm not the good doctor. The doctor बहुत time लगा रहा है. मुझे बात ही नहीं करनी. I just want to take my medicine. So there are patients like that also. So those fits don't happen.
Okay. But then you tend to look at the symptoms first or at the understanding the patient first. Which one is a better way of working?
No, ma'am. So I think I've refined my way of looking at things now. When the patient is walked in also, I'm saying why this patient has come to me now. What does the patient want? I am looking at what I want from that patient in terms of the functionality, as I was saying before, how we can make function. What is happening in this patient now, which I can improve now. This kind of question happens over long term.
Okay.
So if a patient is coming to me for 3, 4, 5 years together, then the family dynamics, patient's personality, all that comes into play. If somebody, let's say, lost a job, come to me with depression for the same, and I'm treated only for 3 months, patient went away, such things don't matter.
Correct. Yeah.
But if that person has lost job and again, since 3 years is not getting a job, then the personality is there. Then I need to look more into detail of it.
Okay, got it. Yeah. The next question is, what is the feasibility of a psychiatrist making a home visit? As a lot of times the patient is often unwilling to come to the hospital and sit through consultation, and even violent at times.
Exactly.
Did you mention, you spoke about this also a little.
No, I don't know. For the home visit, let me tell you, I'm not talking about home visit.
Home visit, yeah, but the other part you did speak.
Yeah. So about the home visit, let me put the rational element. So many times, because of multiple factors, home visits go wrong.
Hmm.
I mean, I'm not trained to, wrestle a patient into submission.
Hmm.
If a violent patient is there who's suspicious of everyone, family members, you bring in me, a new person, doctor. So what? I'm a doctor. What will the person say? Okay, sorry, please tell me. He or she will be more aggressive towards me. Number one. Number two, the moment he sees me and he doesn't like me, I can't see the patient again. Done. I'm done with him. Even if I'm a good doctor, I'm done with him. He will not come to me, right? Because I already intruded into his private space when he was vulnerable. He felt everybody, he's threatened. I've gone into his house.
Hmm.
Those dynamics don't work there. So for me, I've realized over time, first is to teach patient, to counsel the family how to bring the patient to you. Or if patient is so violent, better to get him admitted. That is better, because even if I come and give a medicine now, patient refuses to take medicine, what will you do? Kya karoge? If he's not in that state of mind.
Okay. Yeah, I think, that for counseling the family and then getting him
Counseling the family how to handle the person and making the decision together. Should we admit him for a week or 10 days so that he becomes better?
Yeah.
Once he comes into the senses, please मैं एक और बात बताता हूँ. When patients are aggressive, either in mania or schizophrenia, they do not remember what they do later. वो भूल जाते हैं. They have no memory of this, no recollection of this.
Correct.
So people are always worried. They're not, once they recover, they will not understand what negative behavior they were doing. They will not be apologetic also about, because they will not remember what's happening to them.
Yeah, true.
Yeah. Saraswati, just to talk about this home visit thing, because we have been advocating about assisted home care from FACEMI. Not to talk about an emergency case or where the person is not able to receive the intervention by the doctor or the professional. Cases where the person is not willing to come but requires treatment, it is not possible to forcibly bring also. Like you said, you cannot forcibly enter his space. I see that. But to not get the treatment because the person is not ready to come to the OPD also is a loss for both the person who's suffering and for the family. So I think we need to look into that a little more so that it is helpful for, from the point of view of the doctor and from the point of view of the person who needs the help, to be able to come to some, because we have been talking about assisted home care, especially for PMIs who are not ready to access the OPD services that are available in their cities or villages. So that is one thing I just wanted to bring up. Maybe we can continue with the other questions and go back to this some later. Thank you.
Query regarding how government hospitals take informant statements and why isn't taken down verbatim by the doctor's team for senior psychiatrists to address when the time of consultation comes, and instead informant is asked to repeat themselves multiple times. I know
that's common, right? This is because they are actually also, they are educational institutions also. So unfortunately, that is a trade-off of not paying any money. So once you're there, you're also part of the training curriculum. So a junior will first take, then a senior will come and take again. Then maybe assistant professor will come, and maybe if HOD comes, you're lucky to see, and a big man coming in, they will also ask.
Yeah.
That's part of the teaching process. But we can't help it. That's how this is there even abroad also. So this is how it is. Unfortunately, I don't have an answer to that.
Yeah.
Coming back to that assisted, man, we need a proper system for it. See,
Yeah.
the thing is, for somebody to make house visit, you need a proper team. You need to look at legality of the situation. Not all families, see, you're all here are good not all families are also that understanding, cooperative. There's sometimes other motives also. So that also is a little worrying some for a doctor. So what happens is when a patient is coming to you in OPD and talking to you a couple of times, sorry, the family coming, you build a rapport with each other. And there are ways and techniques to manage the situation, which I cannot say right now. So that can be discussed in that interaction.
Sure.
Because आप भी तो जानो ना, who's this person, which is the family, what if the family, see, because mental illness also been abused by people in framing people. That has also happened, no? Even if it's rare, but it has happened. So you need to be very careful about it.
Yeah.
Okay. Time for another discussion sometimes.
Yeah.
Thank you.
Yeah.
No, but I did like your concept of saying that, which is also, we also talk about that, having counseling the family, going to their house and counseling the family, how to bring the patient to the
Yeah.
OPD. Yeah, I think that's one of the ways also we also are saying through our assisted home care services. Yeah. How must information about a person's sexuality or sexual functionality be safeguarded by the doctor's team to ensure the patient's long-term interest in terms of relationships or responsibilities? I'm not too sure
I think
whether
it
I
is
have.
Actually, there was a lot of,
so there is a
it
patient
was a very
again.
long paragraph that came, and I collated this actually. Basically, she was asking that there seems to be, not so much of confidentiality when it comes to the person's, issues with sexuality or something
What
like that. It
this is
also
for
affects the person's, yeah. Yes, sir, please.
this is for patients of gender dysphoria
Yeah,
who are coming out,
queer.
or patients who have, who are queer or something like
Yeah,
that,
that's right.
or who are gays, who want to commit out and family doesn't want to. And
Correct.
sometimes doctors just immediately tell the family, causing hardship to the patients. It is in this context, I think.
Yeah, even I.
No, sir, it was also mentioned that in case of some persons who are coming in for treatment who have some issues, maybe anxiety and all that, they are married, and it leads to issues between the husband and wife once those kinds of
Yeah,
difficulties
yeah.
are known by
So,
the partner.
so there's a patient who had come to me multiple years ago, married. After marriage, the man realizes that he is not a man; he's actually a female trapped in a male body. So gender dysphoria, and he wanted us to give a go-ahead for the surgery, knowing that he's married. Now this is legally challenging. We also wish him well to get this gender changed, but he has a responsibility, legal responsibility. Yes, I said you need to first discuss this with your wife, get it settled, and then come to us. And then he got divorced and then came to us. You understand what I'm saying? So because we can't, so in such a thing, if I had done that thing, so that's where confidentiality can be breached. Confidentiality is breached when person decision can endanger themselves or others. If somebody says in confidentiality, Dr. Vishal, I'm going to kill myself, I have to call the parents or the family to tell them this person may kill themselves. There's no confidentiality required there to be preserved. Similarly, somebody has some harm of killing somebody else. You need to again inform if this person can be homicidal. That is rare instances, but I'm just trying to say confidentiality is breached, has to be breached then.
Okay. We have Mridula Seth on the chat box. I'm taking questions from there. Okay. Mridula Seth has asked, can borderline personality disorder patients be treated?
Okay. And ma'am, I need to leave in 5 minutes. There's a patient, two patients again waiting. If that is okay.
Okay.
Yeah.
So then I'll just take the last two
No,
questions.
I'll answer this. So borderline personalities, I see a lot of them, and they are manageable, and once they mature over time. So we need to help these people at least cross their 30s. So from 20s to 30s are the most stimulus time. Once we help them cross, then they settle down more with the support, with the medication and psychotherapy. Definitely can be helped, and they can live productive lives.
Thank you.
Then the person has asked is, PMIs are asking how long period should I take medicines? Is it lifelong or some period?
So that depends on the type of illness they have, and what is most important is the functionality again. The whole purpose is to maintain the functionality. I am wearing these glasses lifelong to improve the functionality. I can also work without them, but this is an important thing. I can also get a LASIK done, but this is more safer for me right now, so I'm using this.
Okay.
Nobody says anything about this.
Yeah.
So now with this, when I look at it, my eyes have changed a bit because of those glasses. But that's it. That's a trade-off which we have to do for better functionality.
I'll take one last question,
Yes,
sir.
ma'am. Yes,
Vishal Bansal, would you like to ask a question by unmuting yourself?
Yeah. Yes, I think he's written it here.
And I have a question that was sent to me just now. I'll just, maybe that could be the last one. Mr. Bansal, please continue.
I think he had asked me.
Has he already written in the chat box?
No,
Yes,
he's
no.
not. He said he would like to
Okay.
ask. That's why I thought I would.
So I found this. Can I take this question? It's very interesting. Sekhar has asked, do you help people who are normal in society and family but still not feeling good with themselves? Feeling upbeat or not? Yeah, so Sekhar, for this, I would say yes, though may not be the right person seeing this. Maybe a therapist will be better to help you understand, or a coaching will help you understand why you're not feeling it, what you can do about it to make yourself better.
Okay.
Okay.
Yeah.
I have a question here, Saraswati, that was sent to me.
Okay, go ahead.
Yeah. It says that here is a mother of two children. They're older adults, 44 and 41. The younger one has been diagnosed with bipolar disorder, BPD, PTSD, and DID 15 years ago. And she looks for validation from the older sibling who doesn't seem to understand what she's going through, and he feels that the mother is also spoiling her. And his support means a lot to the girl, but he is not. She doesn't get it, and it would ease the situation, but it's not happening. So the question is there anything the mother can do to help the brother understand the situation better and to be a little more supportive? Because the journey is very tough and there's constant criticism, which is making it very painful and very challenging for the person who's undergoing treatment. What can the mother do in this situation to make it better?
The more open communication is important for them to make her understand their point of view. This is the only way I can say it. What I've understood, 2-3 things about marriages. One, most of the women suffer trauma in the initial 2-3 years of marriage. This is when the man is not aware that a new person has come into the family. He thinks it's normal, that for his life, he's living in the same house that another person is coming. She'll also be comfortable like I am comfortable. But that woman who's coming in feels they have a lot of insecurity so many times. And the trauma at initial, when mother-in-law said something, husband did not support me all that time. Those are the traumas which stay with women for a long time, I've seen. One. Second, despite marrying in the same caste or the same community, each family has their own culture. So each family has their own culture. When they eat, how they eat, when they sleep, what kind of things they do. And sometimes they're so starkly different that also causes disturbances. This is very important to understand. So again, open communication, more communication is the way out of this.
So here, this brother is not understanding that the sister is suffering from bipolar or PTSD. He feels that the mother is spoiling the girl
I
by,
understood.
you
I
know,
understood.
yeah, but
Okay.
so I mean, what I'm saying is, like how you mentioned about married couple, between siblings, and he is married and he is moved out of the family, so he is not living with the sister now. So, how could the mother help? She feels helpless in trying to help the child who is already under treatment, and the other one who is not able to understand what the sister is going through, and the fact that the mother is getting older, and he is the anchor for the girl, maybe in a few more years to come. So that is where her question comes from. Yeah, she's not in the meeting today. She was not able to
I
attend.
get, I get it. I get. So fine. So here's a sibling thing. So it could be sibling rivalry playing out for in a different way. This is possible. It is possible that because mother felt that one child is not doing well. I need to support her more. Which brother detested. Ki why? I mean, I'm normal. Is it my fault that I'm normal? Why she's not loving me more? Is it my fault? Why should she not love me and give all the attention to this girl who's ill because of this? Do you understand the point?
Yeah.
What is my fault in being normal? मैं तो पैसा कमा के भी दे रहा हूँ, मैं आपको वो तंग ही नहीं कर रहा हूँ. Why you're not loving me? So this is what mother needs to understand also. So have this conversation in a different way. Because what is happening is he's asking for love in an indirect manner. She's even withdrawing more from him. He's getting more irritated. And because he loves his mother, so he's taking it out on the system. Look at the dynamics. This is possible one dynamics.
So the sister looking for validation is actually the brother also looking for some kind of validation. That's what you're saying.
Yeah. So because so I think mother should spend some time only with the son. He should also get the love, no? Why should he not? And
No, I don't know the exact family situation right now with her
yeah,
absent
I
here.
also don't
But
know.
yes,
This is
yeah,
because these are very human, very intricate or very delicate personal matters, difficult to us. So this is my broad thing I've told you.
true.
So just one
Thank you.
question which is left behind, I think. Let's
Okay, sure.
finish that if you can just
Yeah,
take it. That
yes.
is, if a PMI is idle in the house, how a psychiatrist can motivate him to work, engage himself, and become
So
independent?
difficult. So difficult.
Yeah.
So difficult. I've tried so hard with many patients.
Yeah. It's the challenge for all our families.
Because once you treat everything else, left is motivation. So this is why I keep asking, why do you want to get better? What is there to motivate you?
Yeah.
You know? So I think we need to probably think out of the box. That's where I am not important. Maybe groups like you are important, where you can share your own knowledge with each other, maybe create some platforms. Because so many of our patients are not ill, but they are not normal enough to withstand the stress of our today's working environment.
Yeah.
Where do you find those jobs? Where are light jobs?
Correct.
Light jobs, chota mota jobs, not paid enough also, but to keep them mentally happy, engaged.
Yeah.
We don't have that gap. We have the huge gap.
Yeah. So true.
Same
I
is with
completely relate to you.
same is with the marriage situation. People who are not totally normal needs also life partners who also needs them. They can support each other.
Correct.
That is also lacking. That's also not there.
Yeah. Okay. Thank you very much for your time. Over to
Thank you.
Sindhuja.
Thank you very much, Dr. Chhabra. It has been really nice that you could share so much of information with us and you answered our questions so well. And I think most of us got the answers. We would, some kind of a clarity about the questions that were asked here. I now hand it over to Ekta for the pledge and the vote of thanks. Thank you so much. You're on mute, Ekta.
Yeah, thank you. Okay, yes. So, yeah, on behalf of all of us, I would like to extend a heartful word of thanks We're grateful to you, Doctor, for sharing this valuable perspectives and patiently engaging with all our questions. Your insights about this placebo or nocebo effect. This was something new. We all go through this, but yeah, hearing those things, it was enlightening. The deliberative model you spoke about and the therapeutic alliance. So those were also very, they were helpful. And this discussion has given us, more understanding or deeper understanding of how empathy, communication, and family support play a crucial role in this mental health care. So, yeah, and so thank you, Doctor. I would like to give a special thanks to Dr. Nirmala Srinivasan, ma'am, for being the driving force behind such meaningful sessions and bringing in fresh ideas for all of us. A big thank you to you, Sindhuja and Saraswati, our wonderful moderators, for smoothly coordinating this session. And of course, my sincere thanks to all the participants who joined us today. Your presence, questions, made this session worthwhile. Thank you. Thank you, everyone.
Thank you.
Yeah, thank you, Doctor.
Thank you. Wonderful. Thank you, everyone. I enjoyed it. I hope I made some sense. So,
Truly. Yes. So, Doctor, please, I know your patients are waiting, so you can go ahead. We'll just, come together, all the participants, and for a pledge. Yes.
Thank you so much. Bye-bye.
Yeah.
All the best
Thank
to
you.
all
Thank you,
of you,
Doctor.
to your families, to your loved ones, to all your PMIs. Hope they all get better and well. And
Thank you so much, sir.
doing
Thank you
well.
for your wishes.
So yeah, I'll call out the FACEMI pledge. We take this pledge to work towards the vision and mission of FACEMI India, to advocate for the rights of our loved ones and care for the wellness of families with respect, trust, hope, and love. Yeah, thank you. Thank you all for joining us today.
Thank you, Victor. Thank you, everyone. Bye-bye.